Yeah, we can hear you.
Yes,
Am
we
I
can hear you.
okay? Okay, thank you. Good morning, consultants and colleagues. My name is Dr. Ogo. Sorry. My name is Dr. Ogo, not today. And I'll be presenting, I'll be answering number 8 question of the last West African October exam, general exam. Okay, so the question goes like this. 52-year-old man who presented with shortness of breath on mild exertion. He developed cough, productive of copious sputum, orthopnea, paroxysmal nocturnal dyspnea, and bilateral leg swelling. He had a history of severe lung infection in the past, and he was previously said to have asthma. This is the X-ray that was projected, the PA and lateral X-rays of the patient. So the questions: A, describe what is shown in the pictogram. B, mention 3 cardiopulmonary signs you will likely pick on examination. 3, what are the possible differentials and likely diagnosis? 4, what are the likely causes of this condition? 5, what other investigations will you do and how will you manage this patient or condition? So in answering the first question, what is shown in the pictogram? The pictogram is an X-ray of the 57-year-old man showing the PA and lateral views. So for the PA view, I could see a prominent aortic knuckle with bilateral bronchoscopal markings, dilatations of the bronchioles, giving a tram-like appearance. I saw something that looks like rings when I expanded it at the end of the bronchiole, and there's this hazy opacity peripherally, which I thought were the rest shadows. Then for the lateral view, the dome of the diaphragm were a bit flattened. It was not as curved as it should be. And I felt also that the right ventricle is enlarged. I don't know whether you can see my cursor. The retrosternal space, usually the right ventricle covers the distal 1/3 of the sternum. However, it feels as if it covers about half of it. Then the second question, what are the cardiopulmonary signs I will find in this patient? So the cardiac signs will include the left parasternal heave, because I'm expecting this patient to have right ventricular hypertrophy. I will see an elevated JVP or an engorged neck veins. Patient will have splitting of the second heart sounds with accentuation of the pulmonary components, because this patient is, I'm expecting this patient to have
We can hear you again.
pulmonary hypertension. There will be a systolic ejection murmur. There will be a murmur at the transcription, should have a pedal edema. Pulmonary signs will include respiratory distress. Can you hear me?
Yeah, we can hear you now.
Okay, sorry.
Yeah, we can hear you.
Okay, the patient might be in respiratory distress, might be desaturating in room air, might have cyanosis, may have wheeze and crackles on auscultation. The chest might be hyperresonant on percussion, and patient might also have finger clubbing. So the possible differentials for this patient include bronchiectasis due to the history that was given. Patient has cough, which is copious, with a copious sputum. And patient also has a past history of severe lung disease and what looks like asthma in the past. Patient can also have a lung abscess, can also be allergic bronchopulmonary aspergillosis. It can also be pulmonary TB with MAC infection. Patient can also have heart failure. So my likely diagnosis is bronchiectasis complicated by cor pulmonale, that is heart failure due to respiratory disease. So the likely causes in this patient, for the primary infections, it might be a Klebsiella, Staph aureus, Mycobacterium tuberculosis infection, might also be a Mycoplasma pneumonia infection. These are primary infections that would have damaged the lung tissue that will lead to bronchiectasis. It might also be due to bronchial obstruction, which can be endobronchial tumors, bronchiolithiasis. But in this patient, I feel the bronchial obstruction will be due to the bronchial blockage due to presence of sputum from the recurrent infections. Patient might be, for this patient might be due to aspiration. However, there was no history of this patient being in altered mental state or having history of GERD. So these aspirations should have gone down. Patient, it might be due to cystic fibrosis. However, there are no other histories suggestive of cystic fibrosis in this patient. Also, it can be due to allergic bronchopulmonary aspergillosis, which comes up because this patient also had a history of what looks like an asthma in the past. And it might also be due to immunodeficiency states, which leads to recurrent chest infections, which this patient has as a history. So other investigations I will want to do for this patient, though the gold standard for diagnosing bronchiectasis is a high resolution CT of the chest, where I will find the pathognomic signs of tram-like appearance or signet ring or enlarged, what's it called? The bronchioles might be enlarged or form blebs. They have 6, but other investigations I need to do for this patient will include sputum analysis, where I will want to do a sputum. I will look at the physical appearance of the sputum. Usually for bronchiectasis patients is very viscid, is very thick, and appears in clumps. Also, I want to do a sputum analysis, MCS microscopy, where I'll be looking out for some microorganisms, including Pseudomonas, which usually colonize the lungs of these patients. I also want to check for pulmonary TB, AFB. I want to do an AFB. I want to also do a gene expert for this patient. For the full blood counts, I'm looking out for, in the sputum, also look out for eosinophilia in the sputum analysis too. So I want to do a full blood count where I'm looking out for anemia or polycythemia. Polycythemia is seen in those that have chronic bronchiectasis. Then I also look out for neutrophilic leukocytosis. I also look out for eosinophilia, which is usually found in patients that have bronchiectasis. I've talked about the chest CT. Then I want to do an echo in this patient. This patient also has features of cor pulmonale, which is a right heart failure. So I want to assess the heart of this patient, where I'm looking out for right ventricular hypertrophy or dilatations. I have to do the check the TAPC, or the cardiologist. They will help us. TAPC, where you measure the pulmonary hypertension. Then I also want to do an ECG, where I'll see features of right ventricular hypertrophy too, like the right axis deviation. Patient might have P pulmonale, might have right bundle branch also. Then I also look out for features of what's it called, PE, as per, just in case patient has that too. Then I'll do a pulmonary function test for this patient, like the spirometry. Usually they present with their findings are usually of that of obstructive or restrictive pattern, and usually is not reversible with bronchodilator. So when I do the spirometry, it will not be reversible. This thing will not be reversible in this patient. Then I also want to do aspergillus persistens and the serum total Ig levels to rule out presence of aspergillosis as a cause of this bronchiectasis in this patient. Then other things that I can do, which are no longer that popular due to new inventions that have come out in medicine, are the bronchoscopy. This is what used to be done in the past. Then bronchography and the electron microscopic examination. That one, I'm not sure. I don't know whether it's available. In that one, you look at the what's it called? You look at the bronchial aspirates. You look at the semen of this patient, rule out cystic fibrosis also. Then for treatment, gold standard for bronchiectasis is actually antibiotics and physiotherapy. Antibiotics to treat for the infection, that drives bronchiectasis, and the chest physiotherapy or bronchial hygiene, which is used to reduce the secretions and ensure that the secretions are all removed. So the antibiotics that I will use for this patient, because of how this patient is presenting, is already presenting in heart failure. So I expect this patient to have desaturated. I expect him to be in I'm not sure this patient is has mild bronchiectasis. So I expect this patient to be in severe respiratory distress. So I want to admit this patient, do my ABC and all that. Then I will now go ahead to administer parenteral antibiotics like the aminoglycosides, which are proven to be effective in this patient. I also want to give this patient anti-pseudomonas synthetic penicillin, and also maybe a third generation cephalosporin or fluoroquinolone, which have been found to be effective against Pseudomonas and all the other organisms that they are sensitive to. Then this patient will also require chest physiotherapy for sputum drainage, which involves posture and what's it called? Vibrations of the chest by the physiotherapist. Also, this patient might also benefit from use of devices, which the commonest we have in our environment is incentive spirometry. This patient will require nebulization, usually with sodium chloride, about 7% sodium chloride. We also require salbutamol nebulization. Also require mucolytics. These are just to relieve or reduce the secretions and help this patient to be able to secrete the secretions very well. This patient will require bronchodilators and corticosteroid therapy. So some of them do very well, especially those not due to cystic fibrosis, but they do very well on bronchodilators and corticosteroid therapy, like steroids, like what's it called? Prednisolone. So other treatments, if you remember very well, this patient also has right heart failure. So this patient will benefit from oxygen therapy. We benefit from diuresis using diuretic like furosemide. Also benefit from the use of vasodilators like calcium channel blockers. Example, the thiazide can be used in this patient. Also, will require anticoagulants because this patient is going to be on admission and will not be very, very mobile because of the heart failure. Other things that this patient will require will be dietary supplementation like vitamin D, which was found that those that have bronchiectasis usually have deficiency of vitamin D. Then other nutritional supplements, which this patient will require for quick recovery. Then, if it's so severe and is not responding to all these other treatments we have required, this patient might require adjunctive surgical resection of that section of the lungs involved in the bronchiectasis. So other supportive treatment that this patient will require are counseling on smoking cessation. The patient has been smoking, whether active or passive. So patient will be required to stop smoking. Then those that are exposed to biomass will be advised to use alternative means of cooking. Then adequate nutritional intake also, this patient will benefit from it. Then patients should be immunized, so will be counseled to receive immunization against influenza and pneumococcal pneumonia. So my overview is not actually complete. That's why I've been delaying to present. So, but I will try and make it up before posting it on the group. Thank you. So please,
Okay,
the
thank you.
apologies in our midst should.
Thank you, Dr. Ogo.
Yes.
For your presentation. Thank you. The class is open for contributions. Questions or comments are welcome. So you can raise your hand electronically, or you can type in the chat box. Okay, while we're waiting, Dr. Anthony is saying that well done for your presentation. So he said, would you like to show us the tram-like appearance and scenery on the pictogram? even though Dr. Ifoma responded and says Seneri is on the CT scan. Then Abu also said diffuse parenchymal lung disease is not a differential. That is asking if diffuse parenchymal lung disease is a differential. And then Dr. Inamdi said, thank you. Please, is there duration for the antibiotics therapy? So can you just take this before we continue?
Okay, I'm trying to enlarge it. So if you look at this area, I'm trying to enlarge it because you appreciate it more if enlarged. But if you look at this area, if I enlarge it,
I
it
think
will
you
be
can
more
enlarge
obvious.
it. Those that are using the phone, you can enlarge it on your.
Okay, because I can't enlarge it from my laptop. I don't know.
Okay.
On my phone, I
So
can't. But if you can enlarge, especially this area,
yeah.
you will appreciate it. I had to scrutinize this X-ray. But if you can enlarge this area, you will appreciate it. I don't know, the pulmonologists I would like their comments, but I saw things that look like tram-like, especially in this place. Then if you enlarge this area, you even see an area where there's, it looks like a signet ring, except I'm seeing it because I want to see it, but please, they will help me. So the other question, sorry, it talked about what?
Duration of antibiotic use.
Antibiotics. Okay, so usually the antibiotics usually for 10 days to 14 days. Then for those that if in sputum analysis they found out that is used to the other variants of what's it called, MTB, the MACs, they will be placed on combination of drugs, which will include ethambutol, the isoniazid, clarithromycin, and sometimes streptomycin, which those ones you will take until they are sputum negative for a year. But for the regular antibiotics like our the penicillin base or the aminoglycoside, they are supposed to get it for 10 to 14 days, bearing in mind the side effects too. But that's the duration of the antibiotics that should be given to these patients. Sorry, what was the second question?
The diffuse parenchymal lung disease as a differential.
Parenchymal lung disease. I didn't come across that, but I know for diffuse parenchymal lung disease, the different parts of this thing is, I think it can be a differential. I'm not sure, but I think it can be a differential because sometimes you also have bronchiectasis that is diffused too. I think it can be a differential, but what I'm not sure is whether they will produce a copious sputum also, but I think it can be a differential. I think so.
Okay. Okay, Maduka, Dr. Maduka wants to say something, so you can go ahead, sir.
Okay, go ahead, sir.
Good morning, everybody. Good morning, my teachers. Thank you for the presentation. I just wanted to point out one mistake I think you made. At least you mentioned it like 3 times. Pulmonally is actually right ventricular hypertrophy following long-standing lung disease, not heart failure. Of course, it can inadvertently lead to heart failure, but the proper definition is right ventricular hypertrophy following lung disease. Thank you.
Thank you.
Good morning.
Morning.
My voice is speaking.
Hello?
Can I go ahead?
Yes.
Okay, good morning, everyone. Good morning, my teachers and all that. Thank you for the wonderful presentation. Okay, just like someone was asking if diffuse parenchymal lung disease can be a differential. Yeah, when you have interstitial lung disease can be a differential, but they wouldn't produce a copious sputum like you have in a bronchiectasis. And then I just want to add that for bronchiectasis for adults, the most common cause will be infection, and then in children have a cystic fibrosis, because what happens is that you have permanent dilatation of the bronchi, which is usually irreversible, and then because of that, they are prone to recurrent infections. And because of this damage in the bronchi and all that, they have chronic hypoxemia that will lead to the pulmonary vasoconstriction. That will then lead to pulmonary hypertension and the right ventricular hypertrophy, which is heart failure. That's that's as called pulmonary. That's heart failure secondary to chronic lung pathology. I don't know if you mentioned the multidisciplinary approach, involving the cardiologist, physiotherapist. I just want to add that. And then for the features that you see, the tram track line, the honeycombing, signature sign, they are actually better appreciated when you do a CT. But that place where your cursor was, I think there's one there. Around that area, if you just enlarge it, I look very well. I think there's a small tram track line there. But I think they are better appreciated when you do a high resolution CT scan. So maybe when you're adding more to the slides, just add a few pictures.
Okay.
It's better appreciated on actually better appreciated on CT. Yes, and then patients with bronchiectasis, they also have what we call exacerbation. Just like you have exacerbation in asthma, exacerbation of a COPD. They also have exacerbations too. So when they have maybe like more than 2 or 3 exacerbations of their condition, because they're prone to recurrent infections, they can qualify for long-term antibiotic therapy, because they sometimes can give them azithromycin for up to 6 months, like maybe like thrice in a week for about 6 months. So the chest physiotherapy is very important because of the sputum production. And then vaccination also very, very important because of the recurrent infections. So when they have the pneumococcal vaccine, it helps to reduce the frequency of the infections. Okay, these are my contributions for now. When I remember more, I'll add. Thank you.
Okay.
Thank you very much.
Thank you
So much.
Dr. Temitope, you want to say something?
Yeah, good morning, teachers and colleagues. Thank you very much for the presentation. I just want to add that I noticed that you didn't put COPD as one of the differentials. It should be there. As much as looking at the chest X-ray, those areas that look like tram track or dilated airways, sometimes the radiologists may really not agree. They will still tell you that, last, maybe they'll say peribronchial coughing or some fluid, or that when it comes to chest X-ray, usually it's when the bronchiectasis is very severe that it's visible. So this chest X-ray can also pass for a COPD because there are some features suggesting hyperinflation with flattening of the diaphragm, and then the AP view, the silhouette of the thoracic cage looks a bit spiral shaped, and there's some increase in the retrosternal airspace on the AP view. So COPD should also be considered here as well as a differential. Yes, and then COPD, a previous severe lung infection is also somebody, I think it was this week, somebody, we discussed COPD, and when he was talking about the etiotypes, he talked about COPD-I, that's COPD secondary to infection, and on top on the list is TB, but any other infection that causes structural damage to the airways can lead to COPD. And when COPD patients have exacerbation, they can have copious sputum, and they can also, and because COPD goes undiagnosed a lot in our environment, so they can present for the first time with features of cor pulmonale. So it's important to consider here. Then you talked about NTM. The treatment for NTM, usually it's rifampicin ethambutol, and a macrolide. And the preferred macrolide is usually azithromycin. And then the treatment is longer than that of the regular TB. It's about 12 to 24 months. Basically, at least 12 months after the patient has a negative culture. So it's quite a prolonged therapy in patients that develop NTM. And NTM can complicate bronchiectasis, can also complicate COPD. And then in our environment, it can complicate patients with post-TB lung disease. Thank you.
Thank you very much.
Thank you, Dr. Temitope, for a wonderful contribution. Let me go to the chat box. So let's see.
Anybody comments on this lateral X-ray too? Because I had issues looking at
Yes.
it.
So okay, the cardiac silhouette.
Mm-hmm.
Okay, so there are mostly features of hyperinflation on this AP view. Starting from looking at the thoracic cage broadly, it looks barrel shaped, where actually better able to appreciate barrel shape by looking at the AP view. Then in the upper part, the retrosternal airspace, the radiologists have a measurement in millimeters that is supposed to be, but just looking at it, it looks increased. Then there's some evidence, like you said, of some right ventricular hypertrophy in terms of the size, and it's completely occupying that lower part. And then also you mentioned that the liver looks flattened, both on the PA view and the AP view. And yes, and the lateral view. So.
Okay, thank you. Thank you very much.
Okay, thank you very much. From the chat box, they say thank you for Dr. Ruka. Okay, Dr. Afion was saying COPD, yes, Dr. Temitope has trashed that. Ruka Nasu says TAPSE is a measure of right ventricular systolic function. Pulmonary hypertension is estimated using tricuspid regurgitation measurement. So just for us to note. Thank you for the presentation. How do you explain the left-sided heart failure symptoms of orthopnea and PND in this patient? That's from Dr. Charles. Okay, Dr. Musokwe is still trying to reiterate measure of right ventricular systolic function. And he said, I didn't hear you mention if there are X-ray features on the heart backing up your diagnosis. Okay. Dr. Ibifiri say 4 weeks to 3 months. I think talking about the antibiotic. There's also rule for Dr. Ibifiri said there's also rule for the 3 times weekly azithromycin at 250 milligram for 3 to 6 months. He also said in acute exacerbation, if non-pseudomonal amoxicillin clarithromycin combination, if non-pseudomonal, you give amoxicillin clarithromycin. If pseudomonal, you give ciprofloxacin 750 milligrams 12 hourly with nebulized colistin for 4 weeks. So if still present, IV pseudomonal penicillin for 4 to 6 weeks with cipro and nebulized colistin. Dr. Ekele say NTM, known tuberculosis mycobacterium. Okay, maybe explaining what Dr. Temitope said. All right, so I think those are the chats. Those are the messages in the chat box. All right, thank you very much. Back to our teachers.
Dr.
Yes.
Atta, Dr. Finde's hand has been up. I don't know if she has spoken.
Who? Dr. Fee, she was the first that spoke before Dr. Temitope.
I've not spoken.
Yeah, she has spoken.
No, she has not. I spoke first. It was Ekele Robert that spoke first.
Oh, okay. I was thinking it was Dr. Fee. Okay, Dr. Fee, you can go ahead.
Yeah, good morning to our teachers and good morning to the presenter. Thank you for the wonderful presentation. In addition to some of the things that have been said, as part of the investigation, serum immunoglobulin is also very important. Gamma globulinemia as one of the etiological causes. Then for the pulmonary function test, is more of obstructive pattern that you see. It could be reversible, but the reversibility may not be significant as what you find in other forms of obstructive lung disease like asthma, so it may be reversible. Then ABG is also important as part of the investigation, especially when they come in acute exacerbation. You also mentioned that bronchoscopy used to be done, no longer done. Well, it depends on the etiology. If you think maybe it's an obstructive bronchiectasis, maybe patient has a lung cancer or has a lymph node somewhere that is obstructing maybe a part of the bronchus, causing the obstruction. So bronchoscopy will still be very relevant in that case. Then for cystic fibrosis related bronchiectasis, sweat chloride test, very important, and then genetic testing. So those are the things we can do for those who have cystic fibrosis. Then in terms of surgery, surgery is more, how do I put it, more, is better for those who have the localized bronchiectatic change. When it becomes diffuse, like you find some of the genetic abnormalities, it may not really do so much. So the localized type, we do well for surgery. So thank you so much.
Thank you very much. Thank you so much. Okay.
Thank you, Dr. Piri, for your contribution. Okay, pulmonary function test usually is of the obstructive. Okay, yes, Dr. Piri just mentioned that. Any contribution for our teachers? Let the second presenter please start sharing your slides so that we can.
Temitope, you can go ahead, please.
Okay, sorry, there was someone that asked a question regarding the left-sided heart symptoms, how to explain it in this particular scenario.
Yes.
It hasn't been addressed. Okay, so firstly, if the symptoms are just orthopnea, dyspnea on exertion, bilateral leg swelling, no PND, then it may not necessarily be left-sided heart symptoms, because in respiratory problems, especially in this case where there's some hyperinflation that can impair the diaphragmatic function, they can have orthopnea, worsening of their breathlessness when they lie down, because you remove the effect of gravity, so it's more difficult for the diaphragm to contract. So they can have orthopnea, and of course they can have dyspnea, breathlessness, and then if the patient is having cor pulmonale, they can have bilateral leg swelling. But PND is more specific for pulmonary edema secondary to a left-sided heart dysfunction. So if PND was part of the symptoms, this is a recall. I don't know if there were possibly other risk factors in the patient for left-sided heart disease, maybe hypertension or smoking. Because for instance, if there's a significant history of smoking, and then the approach to this case might tend more towards COPD, and then even though COPD we call pulmonale, the smoking is also a risk factor for ischemic heart disease, so the patient could also have a left ventricular dysfunction. So that's just my thoughts regarding that. Thank you.
Okay.
Thank you.
Thank you.
Thank you. Because I thought about
thank
it
you very much.
too. Paroxysmal nocturnal dyspnea, whether it's an error. Thank you.
No, thank you. So any other contribution, or we'll go to our next to the next presenter.
Dr. Tanimu, you can go ahead.
Okay, thank you very much for this presentation. It's a very nice one. In addition to how she wants to explain about the PND and orthopnea, I think there can be, even because for the Framingham criteria for the diagnosis of heart failure, clinical and also other things, PND is part of it, but there is not two major criteria, because PND is major criteria and the orthopnea is a minor criteria. So if to say that there, and also there is no features of cardiomegaly with left ventricular preponderance. So in that sense, there is no two major criteria for the diagnosis of the left heart failure. So it can still be, there can still be history of PND, but have not met the diagnosis, clinical criteria for the diagnosis of left ventricular dysfunction. Thank you very much.
Thank you for your contribution, Dr. Tanimo. Okay, so Dr. Fei, say right heart failure can also cause left heart failure due to ventricular interdependence phenomenon. So thank you all for your contribution.
Dr. Ata and the presenter, Dr. Ogo Eunice, thank you so much. It was a wonderful presentation. Hope I'm being heard clearly.
Yes, ma'am, you can be heard.
Yes, sir.
So thank you, Dr. Ogo Eunice, it was a wonderful and lucid presentation. And I must appreciate all the commenters, Dr. Ekele Robert, Dr. Temitope, Dr. Feita Kainde, Dr. Tanimo, Dr. Maduka, and everyone that made one comment or the other. Thank you so much. So I think we can quickly move to the second presenter. It's already, I think it's more than 7:30. But once again, thank you, class.
Sorry, next presenter. We have Dr.
Rogu is in class. He's supposed to present. He was supposed to present yesterday.
Yeah, Dr. Rogu Sope.
Dr. Sope, yes. Dr. please go through the chat box for one time. Through the chat box to know others that are present.
Yeah, Dr. Faboindi. Okay. I think Dr. Rogu is ready now.
Good morning. Sorry, am I audible, please?
Yes, you are. You are audible.
Okay. Good morning, consultants, our teachers, and colleagues. I'm Dr. Rugun, and I'll be presenting the fourth question for the National Postgraduate Medical College for 2023. The question is about medical informatics. So we have questions. A is to define medical informatics, and B is to mention 10 uses of medical informatics, and C is what is hardware and software, and then to give examples, and D is to list ways of storing data internally and externally, and give examples to each. Then what are the two domains of medical informatics? What is the full meaning of EMR and HER, and to differentiate them? And they give 5 examples of EMR, and mention components of EMR, list challenges of using EMR and how to mitigate them, and then disadvantages of EMR and how to secure data when you store it. So for the first question, for the first question, medical informatics is purportedly first used in 1974. Essentially, it is a scientific and systemic field of study that deals with acquiring, storage, retrieval, and processing of medical, biological, and associated data, information, and knowledge for the purpose of problem solving and decision making. Also, to explain further, the AAMC in 1986 says that it's a developing body of knowledge and set of techniques concerning organizational management of information in support of medical research and education or patient care. The term medical informatics is actually being used less now, and health informatics, which is a more encompassing umbrella term, is being used now. However, there are several fields in health informatics. There's nursing informatics, public health informatics, amongst others. So medical informatics is a field in health informatics. The uses of medical informatics are are many. Some of them are here. We were told to provide 10. It is used in telemedicine for data collection, in decision support system, for data privacy, communication with other healthcare providers, patient empowerment, in reduction of the cost of attending to patients and record keeping, and improvement of healthcare marketing, electronic health records, and then health informatics professionals in training them. Other things that are under these will be health data sciences, big data analytics, and then enhanced data storage. For the definition of hardware and software, hardware refers to the physical and visible components of the system that cannot be altered without replacement or physical modification. We were asked to give 2 examples of this, the central processing unit, the monitor, the motherboard, the storage devices and servers are some examples of hardware. While for softwares, this refers to a set of instructions which enable the hardware to perform specific tasks. And these are some of the examples given here: electronic health record software, medical research software, medical research and data-based software, medical imaging software, and prescribing software. Some of these gained prominence during the COVID, where there was limited interpersonal interactions. For data storage, could be internal storage or external storage. For internal storage, we have the random access memory. It could be dynamic or static. The read-only memory, floppy disk, and hard drives. External storage, we have flash drives, DVDs, virtual storage, magnetic storage, and hard disk drives. There are domains of medical informatics, although the question reads to give the 2 domains. However, with my search, I didn't see just 2 domains. I saw 5. This is according to the Joint American Medical Informatics Association. And the 5 foundational knowledge, that's a domain, and then enhancing health decision-making processes and outcomes. And the third one is health, that is biomedical and health sciences, information sciences and technology. The fourth is data governance, management and analytics. And the fifth is leadership, professionalism, strategy, and transformation. The differences between electronic medical record and the question reads HER, I think it's EHR. So is electronic medical record is EMR, and then electronic health record is EHR. Electronic medical record essentially is a digital version of a patient's charts, while digital record of the health information concerning the patient will be under electronic health record. Electronic medical record uses only a chart, while the overall charts and the encounters with the patient will be under electronic health record. In electronic health record, many providers are involved, while in medical record, one provider is involved, meaning this electronic health record is essentially the summary of the clinical encounters of a patient documented from wherever it is he has been seen, that can be accessed by any provider. But for the medical record is usually for the attendance to the patient at hand, and is only available to the physician. Like the next item says that cannot be shared, while for electronic health record, it can be shared. And then the electronic health record is not confined to the person that is using it part-time. For the electronic medical record, patient's information is confined to the healthcare setting where he or she is accessing care at that time. And the electronic medical record essentially used for diagnosis and treatment only. But for electronic health record, it is used for other things, decision-making outside attendance to the patient, and even audit and all of those things. Then examples of electronic medical record, there are quite a number of softwares that are being used and programs that are being used. Some of them are detailed here. Like I said, most of them are gain prominence during the COVID lockdown. We have Meditech, Epicare, Advanced MD, some of them used for investigation, some of them used for prescriptions, some of them used for documentations during patient encounters. The components of electronic medical record are data capture, information management, decision support system, order entry systems, and reporting mechanisms. The challenges of electronic medical records. One is the high startup costs, which essentially means that it takes a lot of money to get it running. Well, the mitigant here is to focus on the longer term use than just the short term use, which is that it may have a high startup, but down the line, it saves cost in recurrent expenditure. Then the reluctance to change on the part of the healthcare workers that may be using it. Usually there would be a need for pre-sensitization before the electronic medical record is essentially put to force, and then training, which is my next option. There is a requirement for training for handling of the electronic medical record in most cases before its use is started. And then issues of network in environments such as ours, where the coverage may not be effective and equal in all places. Network providers may have issues with them in terms of assessing this in a case where you need a network to do certain things on the electronic medical record. Then for need for frequent updates, there may need to be checks and pre-informed scheduled updates in order to ensure that the system is working properly. Then there may be loss of data and security concerns in electronic medical record, which will require that there's a regular backup, especially into the clouds and some other storage devices. Then the need for space being physical here. Electronic medical record gadgets will also need places to stay, and in facilities where there may be paucity of spaces, not all the staff even have places to stay. These may become an issue, but of course there would need to be a provision of space for them to stay so that it can work effectively. Then the format of electronic medical record is pretty much restrictive. All the pages and the things that you would have to use have been created there, so you have to work within the frame of what has been provided. And if there is a need for anything outside what has been provided, it may be difficult to get that done and stored up. Now, some of the disadvantages of electronic medical record are a high susceptibility to hacking and data security issues. The cost of running may also be high. For instance, there will have to be power supply, there will have to be equipment systems and all of those. So it may be high, and then the requirement for power supply too is necessary, especially again in such environments as ours, where institutions may be the ones providing their power supplies for themselves. So this may also affect their overhead cost. Then data security, how to store data and prevent, for data security. One is encryption, which is like a coding to back up and to ensure that not an external body doesn't have access to the data. The regular backup and recovery of the data that have been stored up, and physical security for in the case of gadgets that may need to be physically secured. And then access control, meaning there may be need for designated persons to have access to controlling and backing up the data, as opposed to the general access. And then network security, which is do not transfer encrypted data, unencrypted data over the internet, and then there's a need to store more than a copy of that data, just in case one fails, the other can be retrieved. And then to delete unneeded sensitive data, then encryption of backups too, and then security of passwords, passwords that are not just monotonous, that have several characters, alphabets, signs, and those should also encouraged in order to ensure data security. Thank you for your attention. I think that's the end of the questions.
Thank you, Sophie, for a wonderful presentation. So the class is open for contributions. You can type in the chat box also, or raise your hand electronically. Okay, Dr. Adike, can go ahead. Dr. Adike, you can go ahead if you can hear me. Okay, Dr. Ekele, say, thank you so much for the presentation. Please, what do you mean by EHR, not confined? Does it mean data in the facility can be accessed in another? Dr. Sokbe, did you get that?
Yes, sir.
Yeah.
Okay, yes, I think it's part of the differences that I put up. For electronic health record, it's essentially the accumulation of the healthcare footprints of the patient, not necessarily the summary of the patient's clinical details in a particular facility. For instance, if a patient has used maybe 2 or 3 hospitals in the last, since he started accessing healthcare, electronic health record gives you access to all of that, the data from those encounters. And then you can use that to make a clinical decision. Sort of say you have access to the past medical history of the patient, the investigations that have been done, even not in your facility, you have access to those. But for electronic medical record, it is access to the data of the patient at present. So, and it's usually confined to the facility in use at present. So you cannot access the previous medical history of the patient in other facilities outside that facility. But for health record, you will have access to all of those. Wherever the patient has accessed care, you'll be able to see and know and access the data of the patient in that case. So that's why for health record, it is not confined to the facility being used at present. For medical record, it is confined to the facility in use at present. That's what I meant by confined.
Okay, thank you. Thank you for clarification. Any other questions, any other comments, question?
Dr. Fatima. Dr. Fatima, and it's up.
Yeah, good morning, Chief Christabel, Chief Bansi, Chief Shitu, and all our chiefs present. Just regarding this question, I saw a comment by Dr. Chika saying this is a dry and unfair question. Actually, this was a bonus question. We are very happy to see this question in exams. It is a straightforward question, and that's the essence of coming to this class, to know that nationals don't ask pure stuff. It could be more than 50% could not be stuff you have been doing in your hospital. So this is the essence of attending the class. And if you can have this question in exams, you can score 20 over 20. So that's the essence of attending the class. So don't feel it's a dry one. Just be prepared for it if you are going for nationals. Then my comment regarding the two domains of medical informatics, this is the EHR and the EMR. They are the two domains. And in simple terms, the way to differentiate EMR and EHR is that electronic medical record, that's EMR, is just a digital version of a patient's record, a single patient in a single facility. So, and the information can be shared only within that facility. While electronic health records is a digital version of so many patients from different hospitals, and this can be shared among different hospitals. So EMR is just like part of EHR, but they are the two domains we answered in the exams. Thank you.
Thank you so much, man.
Thank you for your contribution, Dr. Fatima. Any other comments? And we'll hand over to our teachers too.
There's a comment in the chat.
Olaleko said, thank you for the presentation. Please, how do one address the issue of past medical records of patients in a hospital that has been in existence for years, for 20 years, but started EMR about 6 months ago? Did you get that, Dr. Sofer?
Yes, sir.
Yes.
Yes, sir.
So, okay. Yeah, so go ahead.
Well, what I think is, well, my hospital doesn't use EHR or EMR yet. So, but what I think is that when there will be a hospital is trying to convert to electronic medical record, they may also need to go through the patient's folders and also store up some of the information, if not all of the information, in the folder, since they will be discarding. The other thing, well, they should not discard, actually. The manual health record should be kept in a place just in case there is need for recourse to it, but efforts should be made to upload the previous health records in the patient so that the information is not lost. I think that's the direct way, the most direct way that I can figure out that can be mitigated.
Yes, in addition to that, well, my center just started EMR, so we have been having issues here and there, and these questions come up. So what they do, or what they say they will do, is to scan the folders available and then upload them into the EMR so that, eventually, doctors will have access. So every information of the patient, no matter how long, will be uploaded, and then you can pick it up from there. So I don't know if there's any other. Okay, Dr. Dike wants to say something.
Oh, sorry, I didn't put up my hand. This is Dr. Shitu.
Oh, okay, sir. Welcome, sir.
Yes, I just wanted to lend an ear to this. Well done, Dr. Mushakwa. Although I should say I have a conflict of interest from my center, so I know him very well, and he did very well. So when converting from basically a regular case notes to electronic medical or health records, as case may be, there are stages, and I'm sure in every center there is some level of digitalization of the health record. It's either the basic information of the patient has already been digitalized in the system to help locate and retrieve the card. Okay, and of course, also when they are cataloging for putting together data. So almost every center has some level of digitalization, even though it may not be a full electronic medical or health record, as the case may be. So in the process of doing that, usually once a center wants to start electronic medical records, the normal practice is to new patients that come in directly on all cases are supposed to be transferred into that system. So that's why sometimes it costs a lot of money to switch from regular case notes to your electronic medical or health records, because there's going to be a lot of data entry that has to be done. And of course, there'll be a lot of errors because a lot of people will be trying to shove it in. So what they tend to do is they do a hybrid in most centers. What happens is, as the case notes are being digitalized, you can't stop seeing the patients. The patients still have to be seen. So newer consultations are uploaded on the system, okay, while the older information are still being put in. But when the patient is being seen physically, the folder has to be present, even if you're using the electronic medical record, so that you can get all the information that may not have been uploaded on the system. Okay, so gradually it is then phased out. Now, what happens to folders that are really old? Now, usual practice in hospitals is, depending on the location, most times I think it's 10 years that they keep records. So any record that has not been touched in 10 years is usually destroyed. I think that is the accepted practice. So if the patient has not shown up in that center and that folder has not been retrieved in a 10-year period, they can actually start to destroy them. And that's why you still have some space in your health record, because at some point they will have to destroy some of those folders. So what many centers are doing now is that rather than just destroy them outright, with the hope that perhaps they would someday need, someday get electronic medical or health record. What they do is they may scan those records so that later on they can upload it onto the system, so that those records can be located. But if you're starting your EMR already and the data is already 10 years old and the patient has not come to the hospital in 10 years and the data can be what now destroyed, this type of data is usually just destroyed. Okay, so there's no need to start stressing yourself and start uploading that data all over again onto the system. But it all depends on the type of electronic medical record you're using. If you notice, Dr. Orogun mentioned many different types. So different types have different ways of uploading old data and things like that. So it's also dependent on the type of record that you are using at your center. Yeah. So that's just what I wanted to just add.
Okay, thank you very much, sir.
Yeah, you're welcome.
Hello, Dr. Atta.
Yes, ma'am.
Dr. Adela, are you speaking? Because we need to close the class.
Good morning. Good morning, Artie. Thank you so much, Dr. for your presentation. I just want to make a little comment on the examples of the EMR. There were some examples that was given, particularly in the update, and I think they wanted to hear those ones, like the Open Vista, What Vista K, practice. Like if you mention other ones, they'll be looking at you until you mention the ones that they gave us during the update. So I think for those going for the national exam, they should read the update notes over and over again to remember those ones. Components of the EMR, like for us, for those that are using EMR now, all the components they wanted was what you see immediately you open the EMR page, the clinician's notes. After the clinician's notes, the patient's biodata, first of all, the clinical notes, the pharmacy order, radiological results, and all those things you see when you open the EMR, the session you go to one after the other. Those are the components they wanted to hear. Then those on the software part, the simple things like Microsoft Word, Excel, PowerPoint, we shouldn't forget all of that as well, because it gives us that. Thank you. Those are the additions.
Thank you, Dr. Adiola. Please, you will do us a favor. Upload the document you're talking about for those that didn't have that particular update, please. Thank you so much. Dr. Atta, thank you. So I want to thank the presenters today, Dr. Ogo, Dr. Sokwe. Thank you so much. It was quite lucid. Both did wonderfully well. We appreciate your time, the time you took out to prepare the slides and present it well. Thank you so much. Our teachers, thank you for coming to class. Chief Cookie, Chief Chitu, Chief Bansi, Chief Remigus, Chief Manza, Dr. Adiola, she's a fellow now, Dr. Fatima, then I don't know if I've seen other names, and every other person present. Thank you so much for coming to class. I appreciate your presence. Just a word from Chief Cookie, Chief Titu, then we'll close the class.
Yeah, good morning, everyone. Yeah, thank
Morning,
you
ma'am.
very much to the presenters. Just as Chief Christabel has said, it was a very wonderful presentation this morning. So I'm sure that by now the candidates are seeing the pattern of the exams, so as much as possible, please be abreast with current happenings, because the exam is one which takes into cognizance things that are happening, currently. So you need to update yourself. And it's also important that you get hold of the updates for West Africa and also for national most especially too. So please go through your update materials so that you can be abreast with the latest things. Because if you are using, you are guessing, when they tell you to define something, they love the definition being as it is and having all the keywords in the definition. So that boosts your mark. And just like Dr. Fatima said, there are certain words that they are looking for, and then it's very easy to pass this station that has been lifted directly from the update material. So if you've read it and then you give it to them as they want it, then that's one station that you can get all the marks. Unlike other clinical scenarios, that one or two things may go against you. So just do that, and I know that you will all pass. So thank you for your participation, and I wish us all a beautiful and productive day. Till we meet again tomorrow. Bye.
Bye, ma. Thank you, ma.
All right. Good morning, Dr. Cookie. Nice to hear your voice again. It's always nice to hear your voice.
Good morning, there.
Yeah. All right. Cool. I'll call you later. We need to talk about something.